Today's case of the week deals with a relatively common scenario, and I'm actually going to recruit you, the viewers, to help us out here. I have a solution that I had to deal with this, but I know there's got to be plenty of other ones too. So this is, again, a situation that's kind of particular most of the time. 80% of the time we see this, it's on lower bicuspids, just as this. So we've got a double arch impression that was taken for two BruxZir crowns next to each other. This on teeth number 20 and 21. And first of all, when you look at the impression, even though really what we're talking about here is undercuts, as you'll see, as I look at this impression and I hold it up to the light, and instead of holding it up to the light, I'm going to do the opposite. I'm going to take my iPhone 6 Plus. Yes, I know I needed to get the bigger screen. And as I look through here, usually we'd hold this up to the light and we want to make sure that the unprepared teeth are in occlusion. So we can see those two appear to be in occlusion. Of course, the preps won't be if they've been reduced enough. If we can see light through the impression of the preps, we got a real problem. But we don't see any occlusion on the first molar here, but we definitely see some on the second molar, but none on the first molar. Of course, there is an opposing tooth there for that first molar to bite with. So I have to question, when I take this out and this impression comes out of the patient's mouth when it's set, I look at it, and if I look at it and I see a first molar that doesn't show light through it like I think it should be, I will look again if I need to and look in the patient's mouth and see is in fact, and maybe run some shim stock through it, is in fact that tooth not contacting the opposing tooth. That's really kind of the least of what we're talking about here, but when you look at the bite registration and see that lack of contact between the first molars, I say, is that really how this is? Now it looks like that tooth has maybe been ground on, that upper first molar, so perhaps that's the way the patient was actually biting down. But that's certainly something, and you can see maybe there's some contact with that second bite and that lower first molar that you could see that little light showing through on the impression as well. So perhaps that's actually where it is. And if that's the correct bite, as if we look at the reduction from the scan and pull back a little on the zoom, we'll see that we have, in fact, on tooth number 21, 1.58 millimeters of reduction, which is enough for BruxZir. In fact, it's even enough for Emax, more than enough for Emax. It's ideal for BruxZir at 1.5, and it's great for Emax too. And if we look at tooth number 20, 1.57, so almost exactly the same, a tenth away from that, which is pretty amazing that he got so close on both of those. Maybe he used a 1.5 millimeter depth cutter. I'm not sure. In fact, when you look at the margin here, it looks like he used that round burr that I like to use on my reverse prep technique. You kind of get the feeling on that one that you can definitely see that. Not so much on the tooth next to it, as we'll look in a minute, but it definitely looks like on that one. That's what my preps typically look like using the round burr at the margin before I've blended all the axial depth cuts, for example. So the scan that's really most indicative of what's going on here is when we just isolate tooth number 21. And you can see as we've scanned it here, everything that you see that is in red is an undercut. So there's even an undercut in the incisal third of the preparation, and certainly this mesial wall has a lot of undercut on it. There are certain things, like down in this area, this gray area here, where the scanner can actually see the margin along here, but then this margin all disappears, and this part of tooth number 21 is all out of view of the scanner as well. And so there's a big undercut, and this case is going to have to go back to the dentist for him to prepare a little more so that we can get a taper on here so we don't have all this part of the tooth in undercut. Interestingly enough, the deeper the gingival margin is here, the more likely we are to be able to block this out and still make a crown that will fit at the margin. And that's part of what's going on here, is that we have a deeper margin here. And so we'll be able to block this out, and we could get the margin here, but we lose it completely all the way along here. So let's take a look at the solid model and see what we can tell from looking at this preparation. And so I'll just turn it sideways. And again, it's going to be a little tough to see. I'll tell you what, let's look at the trimmed model so we can get a little better look at how the gingival margin looks. And so you can see that's what we saw in the scan too. On tooth number 21, it looks like the round burr was used. Not necessarily, but I'm just used to kind of seeing that on my own preparations. And maybe it was used there, maybe it wasn't used. And as we turned to look down, we were always taught that we should be able to close one eye and see all our margins at the same time. And you can see how if I hold it just like this, that on tooth number 20, for example, we can't see that lingual margin. But as we turn it, now the lingual margin comes into view, and we can still see the buccal margin over here. Even though it looks to be kind of an undercut there, but we can block that out and still see that margin. Now, holding this and moving it around is so much easier in the lab, so much easier for a scanner than it is as a dentist trying to do this intraorally. And that's really almost kind of impossible. And you can see how long these preps are. And this is why it's these lower bicuspids where these things tend to happen. This is, like I said, 80% of the time, it's these lower bicuspids and sometimes upper bicuspids where we're going to have these types of undercut problems because they tend to be on really long preparations. You know, typically we talk about a short preparation being 3 millimeters or less, and here we're looking at, as we look at this and hold the probe next to it, we've got, 3, 6, 9, a 9 millimeter long preparation, probably because of gingival recession. And a 9 millimeter long preparation is going to be very difficult to make it so it's not undercut. In fact, you almost have to over taper it, or you have to do additional occlusal reduction. The shorter a prep gets, the easier it is to visualize the amount of taper that's on a tooth. So according to the scan, if the bite is correct here, we have 1.5 millimeters. And I'm confident we could take off another millimeter, be at 2.5, and maybe be able to visualize the taper a little bit easier. I'm also wondering, though, is that bite accurate? And maybe we don't have the 1.5 that we think we have. In my reverse preparation technique, I do a couple different things. I start with this round burr preparation in the gingival third, and it's the most shallow of the depth cuts that I do. And then we're going to do an occlusal or an incisal depth cut, but we also do an axial depth cut in the middle third. And that really is the depth cut. So it goes from shallowest depth cut to slightly deeper here to the deepest at the incisal or the occlusal. And then when we blend those depth cuts, it's really that axial one in the middle that's going to guarantee that we don't get undercuts. And so what if a dentist were just to do an occlusal or an incisal depth cut and use the round burr here? Well, it's pretty easy to end up with this type of result where you end up with an undercut. So, clinically here, when we don't have enough reduction, we can often just make the dentist a reduction coping, but you can probably see how difficult this is to make an axial reduction coping. So even if we come in here and we prep this tooth more along here and then make a reduction coping with a little window, it's really difficult to do. And right here on that mesiofacial is where we really get an undercut. We have to tip it way over to be able to see that margin, but then we lose the distal lingual at the same time. So it is a tooth that is under reduced. The way that I always do it, again, is with that axial third depth cut that comes in here right around the junction of the incisal third and the middle third. And by doing that, when I blend the depth cuts, by making that depth cut disappear that's placed right around here, I tend to get away from this. So I'm interested, and again, you can see with a deeper margin, like the one here or the one here on tooth number 20, that if we do in fact have an undercut here, we can block all of that out and still be able to see that margin, and that will allow us to get a good seal on the crown and you not have to get the patient back and necessarily do any more preparation. So my challenge for you is tell me your best way to avoid undercuts on teeth like this. We were taught in school to go for 8 to 10 degrees of taper, but that's a very difficult thing to measure in the mouth. And I always joke that nobody makes an oral compass anyway, like a protractor and a compass, to go in there and hold it up and do it. Yes, you can kind of try to do it with a perio probe, but it's much easier to do, out of the mouth, where I take it. I'll try to tilt this so you can see it. Where I take it and hold it against this tooth, for example, on number 20, and then have to angle it in to touch in the gingival third. Now you can see that it's in an undercut situation, and then if I roll it back. So in the mouth, this is difficult to do with a burr or a perio probe. It's almost one of those things where you get the feeling that if the assistant, when she made the temporaries, would have let them sit on for 4 or 5 minutes, like Bisacryl temporaries, when she went to take them off, they might have snapped. It's hard to believe it came out clean, here and here in these undercuts without getting stuck and breaking off. So maybe that's one way to do it, but I do it with the use of the depth cut, the axial reduction depth cut at the junction of the incisal third or the middle third. to help me get away from these undercuts. I'm interested, what clinical tips do you have? What do you do in your practice to kind of avoid this situation, especially on lower bicuspids, especially on cases where there's been some gingival recession or periodontal disease? What do you do on these super long preparations to make sure you don't have undercuts? Because whereas we can make the crown on this tooth, doctor's going to have to re-prep and re-impress on this one for us to be able to make a crown. So I want to hear from you guys. What are your clinical tips on these long types of preparations for avoiding undercuts and having to get the patient back and re-anesthetize and re-prep? Please email them to us here at Chairside Live, and the winner will get some sort of nifty prize yet to be determined.